Right. Right. Okay.
Yeah.
So,
So I would say that if I would try and construct some predictive models from the data we already have with ROPAC, and then we will test those predictive models on the data we get from the registry, and it'll depend on how much data we get as to how long we want to go on testing it for. And once we believe the models work, then I think we could try and do some, as you say, later do the randomized trials, which would be early intervention. For example, beta blockers, diuretics in some women before they become unwell. And I think that's how I would like to manage it. If you felt that was a reasonable way to approach it.
no, that's fine. Perfect. See, another advice, I was just wondering within my mind. There is actually a group by the name of WinCars. Cardiologists are there. Oh, so
Working tonight.
this is this is a group of women cardiologists across the country. Cardio obstetrics is actually of interest to women cardiologists, generally speaking. So we can maybe rope in that group, or we rope in the cardiology group, or have the FOXy. I mean, or both, make a collaborative sort of a thing.
I would do
Because
that.
sorry.
I would do that. I would try and make it as broad as you could.
Right. So after we meet today, I will write to the FOXy president. Maybe we can use Alpesh, or we got to know Alpesh Gandhi at that time during our panel discussion, and that's the first time I met him. He seems to be pretty much involved with the FOXy phase. So, and I'll also find out who's and then make it as a collaborative kind of a registry. Okay. So in this registry, when we register this registry, can we put your name also, because that will attract more people with your ROPAC experience?
It'll be a pleasure. I also spoke to Jolien Rouse Hesselink. Do you know Rolene or Jolien? She ran ROPAC out of the ESC.
Okay. Okay.
So she would be very happy to help if you would like her to help.
Oh, absolutely. That would be really great, because once you and she are there, that will actually solve a lot of issues in terms of planning how we go about the registry. The logistics, how we get people recruited and all, should remain. I mean, I can do that. That's not a big issue. But what all to include, how to make it reasonable. But as we travel further, we need to tell you that the level of data collection is not going to be up to the mark as you had in ROPAC.
Yeah.
A lot of these centers do not have actually a functional cardiobstetric clinic. These are the ground realities. And obviously, when you do a registry, you really want to unveil the ground realities rather than. So all these factors will have to be indexed in it. And then maybe a pro forma and a study plan can be made, and then we can.
Yeah. So if you're happy, I will ask Jolien for the what's the word I want? The patient form, the electronic data form from ROPAC, and we could use the similar one and we can change it a little if we felt that was useful.
Right. And ROPAC, you had written in your editorial, didn't have the arrhythmias or something?
I beg your pardon?
It didn't have the rhythm abnormalities. The ROPAC, I don't.
It had all heart abnormalities, so they were congenital as well as acquired heart disease, and people who were pregnant, basically. So we looked at all aspects. It didn't have very many cases of ischemic heart disease, but I don't think we should limit it to any particular type of heart disease.
Right. So all pregnant women who have a heart issue, whether it is a rhythm abnormality, acquired congenital, valvular, all become part of the registry.
Yeah. Or vascular. So history of dissection is just
vascular also. And the hypertension group does not come in.
We didn't include the hypertension group.
Because it's going to be very hard to differentiate between preeclampsia and hypertension.
Yeah. I don't think
there'll
be a. I think it gets too broad if we include hypertension.
So preeclampsia and hypertension will not be included.
Yeah.
Right. And roughly, how much duration do you think this registry would
So I
should
think
run in for any meaningful information?
I think we probably need to start for 2 years, validate our predictive models, and then we use the group to do some prospective studies, randomized studies. And if we can establish the group, then that would be a very, very good group also to do the work with anticoagulation.
Right. Yeah, that's actually what I was having in my mind is that rather than I'm not too sure what models you are actually thinking of, but maybe the models come in after a year or so.
So I think we have some data within ROPAC which would tell us who is most likely to go into heart failure.
Okay.
And so if we say, okay, if you have these parameters on entry, we would predict that you would have an N chance of going into heart failure. And if we find that our models are predictive, then we can start saying, okay, we would randomize you to having an intervention at the beginning of pregnancy and see whether we can reduce the risk of that complication arising.
Okay. And there won't be much point in including this group from Tamil Nadu because they are already committed to a state registry, which he has mentioned in that. So let's make it, or should we include them? I mean, because
I would include them because they are already organized and set up, and I think it's a good model to use for states which don't have that model.
So should I write to him, or would you like if you people are in touch with him, or because I know this fellow Justin Paul. So I can write to him. Maybe
I would write to him. I think it's much better if you didn't mind doing it because it's something you're driving it, which I think is a great.
Okay. So what we can do is let me write to a couple of these two associations and also Justin. My only fear is Justin is already committed to his state registry. So will he like to share the data with us or not? That can become an issue.
Doesn't matter if he duplicates. Doesn't matter if he duplicates.
Won't be a duplicate.
I mean, he can.
He can. So, for example, we do here in the UK, we wrote our own papers as well as contributing to ROPAC. So,
Or you also.
Yeah. So I don't think that's
these patients can be a part of the main registry also. The ones
I think so.
Yeah.
Yeah.
Okay.
He can continue to do his work for his Chennai kind of group, but he can also contribute to the registry. And actually, it might be easier because he will be able to drive centers around him, and it'll be easier to get people.
No, he has that legitimacy, and people. In fact, this particular paper is being talked of a lot in our cardiology circles. Last 1 week, there a lot of people are actually, because it's the first pregnancy related data from our country. So it is being mentioned and discussed, and people
you
know
might be able to source the metallic heart valves patients easier. So if you're more interested in a particular subgroup and he's got the entire population of patients, maybe then you can say, okay, report.
He had an unusually large number of metallic heart valve patients, 60 actually. If I had to guess, I would have guessed that single center will not have that many patients actually. So maybe they have a pooling or I don't know what, because to have 60 patients in one center of metallic heart valves is a very large number by imagination. But,
I'm sure government medical colleges would also have.
Not across the country.
No.
Yeah, because Tamil Nadu has a very structured health system. And their STEMI program is one of the best in the world. Their STEMI response rates, and only 2 states in India have kind of a networking. Because see, living in England, you people cannot believe that how systems can be in different parts of the world. So unless you realize that, you will not. You have a very structured system. And you people can approach, and your electronic retrieval is very strong. In rest of the parts of the country, actually in India, it will be very, very. There won't be any connections between people, and they would not have a regular system. Some of them would not even have participated in a registry before. So those are issues which will, but unless we go to those people, I don't think it will become a meaningful registry.
Absolutely.
Because if we limit it to very high-end centers, tertiary care centers only, we will not get a profile. Of course, we will need some tertiary centers, but we also need some centers which have actually a larger number of patients they are managing. So in my guess, actually, this registry may not be representative of national Indian scenario. So we can start working on it, and as we go along,
Brilliant.
yeah. If you can write to me the name of the lady who you said was driving the ROPAC, and
So she and I wrote the editorial. So her name
she's okay, from Rotterdam.
Exactly.
Jolien. Okay, Jolien. Okay, right.
She would say Jolien.
Jolien.
Okay, so she's the
Like
first one. Okay,
Jolien.
all right, good. Okay, then I think we can keep her in the loop, and
Yes.
let me write a proposal. Gurleen can write it, and we can all work on it, and then we will share it with you and share it with her. And meanwhile, we can get the ROPAC pro forma, and we can involve the associations, and then get going on this. You can let me know what are the models, because I am new in this. What models you would like to test? I really don't know, much about that. So what are the known models that we really want? But that, I think, it will come at the stage of interpretation only, not at the stage of data collection. Or will it be?
So what I'd like to try and do is use the ROPAC data to derive the model, and then we can then test that model in the data as soon as we start acquiring, so that if we say the model works, then we can then move directly to intervention.
Okay.
And I think that will be attractive to people. If we say to them, yes, let's do the registry, they'll say, okay, fine, but what are we going to do about the problem? So I think if we say, and this is our intention, that within 2 years, let's say for sake of argument, we will be starting prospective randomized studies. And how you manage who leads those studies is your call, in terms of, you may want to ask one center to do one study, another center to do a different study. And that I think would require your input and understanding of the people involved as to who would do it and actually do it. They do one thing to say they'll do it, another to do it.
So. Yeah, that's what I was thinking. As we move along, we will get to know, because some people promise more than what they can deliver. It's hard to predict, actually, before you actually do it. That's what I've seen, at least in India. Some people you don't expect they perform much better, and it's very difficult to see, to kind of make out before the study. So as we move around, we'll see which are the more active centers out of the ones, and then we can, right. So that's about the registry. Do we discuss about others, or let we get going with the registry and then maybe discuss the other issues later? What do you feel?
As you wish. I have put down various ideas, and I'm very happy to discuss. If you feel, I think establishing the registry is a good place to start. Mm-hmm. Within that, then you could then put into the study of anticoagulation with people who are contributing to the registry, because they are obviously motivated and want to get on with it. Similarly with the with the studies with the valve. So maybe establishing the registry is the first step, and then the second step is the other studies using those groups, those obstetric medicine groups and the cardiac obstetric groups, who would probably manage quite a lot of the cases that we're talking about.
The preeclampsia thing looks very attractive to me. The ones who survive preeclampsia, and subsequently we define that as a high-risk subgroup. And
yes,
because I don't know much about diabetes, what percentage of them ultimately develop diabetes, those who have GDM. But this aspect really attracts quite a lot. And maybe we can then subsequently work on this issue.
Yeah, I think that would be great. But as you say, I think establish the registry, then we can use those people to do the other studies.
Can I ask what you want to look at in the anticoagulation? What
So
do you
we
want
would
to
just
see?
randomize people to placebo aspirin.
Placebo and aspirin.
Yeah.
So this placebo and aspirin, which group of patients we want to
The people we identify as high risk on the RCOG
For-
screening,
Preeclampsia.
VTE.
Oh, for VT. Oh, you don't want to start Clexane.
No, I think that the easy study would be just currently people get nothing. So we could just compare aspirin to placebo. And then that would validate the next study, which would be aspirin versus low molecular weight heparin.
Okay.
But in the valves, we need warfarin versus low molecular weight heparin.
Yeah. Yeah.
So we would have to do that in tertiary centers.
Yeah.
So if I search for high risk or moderate, because I was reading somewhere low, moderate, and high risk, 3 groups.
Yes.
The RCOG has divided.
Yes.
You want to look at the high risk, not the moderate.
So
I don't
would,
even know whether there is that much distinction between moderate and severe, or maybe you people can share with me.
I think we should first ask a few obstetricians what they're actually doing for Clexane antenatally and postnatally, and what is their guidance of giving aspirin. And I think that should be
Actually, Gurleen, I was also thinking this thing that
Oh.
current practices
yeah, you'll have to
are
ask
going to be so diverse in this country
Yeah.
that current practices related to this itself can be a study actually.
yeah.
What
Yeah.
the variation of current practices is going to be huge actually. So
yeah.
even for the registry, I was thinking the initial part would be what are
You
the
have to
current
be able to
practices?
see,
Hmm.
yeah, what people are using.
Yeah.
So,
No, that's
so
a good
you
idea.
might be surprised that a few centers will be using Clexane
Yeah.
For their high risk population. So if somebody's actually had, so I think where they're very good at using Clexane is recurrent miscarriage.
Yeah.
They would use it for everybody because they believe that kind of prevents you.
Okay.
I think that's probably the only place you'll see a lot of aspirin and Clexane being used. And I think we can see, we'll have to check, we'll probably write down to a few centers and see what is your guidance of using Clexane and aspirin. And I think that'll give us an insight as to what different people are doing.
So maybe
It's
we
going to be-
establish the registry and
Yeah.
use the registry to do that sort of survey.
Yeah, yeah. Yeah.
The registry patients are going to be the high risk ones.
So I
Within
mean,
the registry patients, the WHO 3 and 4, they are the high
Right.
risk.
You can have one and
I'm thinking that we could use it's a different question in terms of what you do for VTE risk. But if we get a whole cohort or a group of people who are willing to contribute to the registry, we can ask those people the questions.
Right.
oh yes,
maybe-
I think that's a very
maybe,
good idea. Yeah.
So maybe the registry let's get going with the registry first, the logistics and yeah.
But for
And then
the
as we get to know more people, we have a couple of Zoom meetings with them.
Exactly.
And we all understand. And maybe, then
there's one lady called Nivedita, who actually trained in the UK and then went back and set up a huge department in Baroda. So we can kind of touch base with her and she will understand the differences in practice because she's worked here as well and she's gone back. And I think there are a few other people as well. And they will probably link and tell us what the differences in the practices. Because when I was there, people were using Clexane a lot for recurrent miscarriage. I'm not sure how much for VTE prophylaxis as such. So I think then we can say these are the high risks or whatever. And I'm sure if somebody looks back and sees the maternal mortality in a particular center, maybe in DMC and Government Medical College and Government Hospital Ludhiana, and sees how many have died from a PE, we will then be able to say this is the rate of deaths. And I don't think that, and we can ask a few people what they're doing for VT prophylaxis, and you'll realize they're doing nothing.
actually, Gurleen, you will understand more than Mark this thing. In fact, this is exactly what I was thinking yesterday, that government civil hospital in Ludhiana does 600 deliveries a month, maybe 1,000. And unless we pick those patients people are not even getting echocardiograms done.
Yeah.
I mean, people are not even examining them properly. So let's unless we recruit such centers in the registry,
Yeah.
we are not going to get a true picture.
So basically what I think you need is a person who's not a medic, who's like a nurse, who is willing to work on a nurse salary and goes to the center and actually collects data for us. And that's her only job. And I think that way. So we probably need a little bit of funding from some pocket, ICMR or British Heart Foundation or something. Nothing massive, a little bit, and then you've got 3-4 people like this who literally go to Government College Patiala, Civil Hospital Ludhiana, DMC, look at the maternal mortality and look at the causes. And then I think it's going to be a quick snapshot. I don't think there's anybody doing that. And then you probably have over 30,000.
Unless we recruit the civil hospitals, only medical colleges are not going to give us.
But their staff is not going to do it. So I think you need permission for a staff, for a nurse specialist to go there, collect the data, and then that's it.
But equally, I think you'll find it easier to get the funding if we already have the centres recruited.
Yeah.
So asking them get the registry established and then go from there.
I don't understand why you want to look at aspirin versus placebo, just from my understanding.
It depends if they're already using low molecular weight heparin, then fine. But if there are some places where they're not using it,
they're not using for VT prophylaxis, I know. So then
you could justify doing a placebo versus aspirin study. Okay. Because aspirin would be better than nothing.
Okay, fine.
And according to the latest New England paper, did I send you the New England paper, complete or not?
I think maybe you sent it, or I am aware of this actually. This paper, I have read this paper. Aspirin, I think it was this year only. So maybe
it just came out this month.
Right.
So it was aspirin versus low molecular weight heparin.
Yeah, I've seen that.
And that showed sort of non-inferiority of aspirin,
which is
why I think we could justify aspirin versus placebo in places where they're not giving anything.
Even the American guidelines are very, very less aggressive as compared to your RCOG guidelines. There is a huge difference.
Yeah, it doesn't surprise me.
So I think that's good. Let's start then. I think we had some useful discussion. Let's start with the registry. Let me start working on it, and then I'll send you the rough draft. Then we can all.
So the just to get facts right, the registry is for cardiac patients, but when you're looking at aspirin versus nothing for VT prophylaxis.
No. Registry is general. This is the second part of the discussion.
No. So registry is only for cardiac patients in pregnancy.
Right.
Okay. When we are talking about, because he's not an obstetrician, I think you're mixing it up. When you're talking about nothing versus aspirin, it is for anybody who's pregnant. So your risks of having a clot would be raised if you're pregnant and you're over 35, you're obese, you've got another chronic health condition, you've got SLE, you've got autoimmune conditions, whatever.
See, that's what Mark said just now, that let's get linked up with some centers for the registry. So and once we are linked up, then we talk to them about this aspect of looking at placebo.
You're right. But in the interim, what we can probably do is just maybe you can talk to Pooja and ask her what they are doing for VTE prophylaxis, because they're very aware of the RCOG guidance, right? So just what they do. So and I can write to her as well. I'll write to her and I'll ask her and see what they do. And then this is a separate part. This is not cardiac disease in pregnancy. This is just general VT prophylaxis in pregnancy.
Right. Sure.
And I think what we can do very easily is survey 10 obstetricians and see what their practice is for VT. And those many I would know in different parts of India anyways. And I could probably just send an email to each one of them to see what you guys do or what guidance you're following or what, how much of Clexin do you use for women who are obese or BMI over 40 this time, and see where we get to.
I mean, what I had thought was if we establish the registry, then we can ask members of the registry what they do, and not saying that we want to collect the data from them, but they may say, we could find the data for you if you wanted, if you see what I mean. So it's more a conversation of let's get the registry established, and then talk to them about all the ideas, and see what they feel about that.
Yeah, sure. Okay, then maybe in 2 weeks' time, we will have some movement in terms of the registry, have more people recruited and see, and then we meet up again maybe 2-3 weeks. Right. Okay.
Perfect.
Okay. Great talking.
Look forward to it.
Yes.
Thank you very much.
Thank you.
See you soon.